Jim. Dr. McKinsey's going to start and pick up the momentum later. Thoracoabdominal or type B dissections indications for endovascular treatment.
Thank you, Rod. I'll have to say this talk has been significantly modified. Thursday I got a phone call and basically said that our talks tend to be boring, or my talks tend to be boring. We have about 50% of the audience on their laptops, on their phones, and everything else. So said, do something different. So this is something different that's been evolved over the last couple of days, and tell me if you like it or not. So, as I said, people tend to pay attention as you do case presentations. So I'm going to start this with a case. I'll try and start this with a case. There we go. But what you'll see is as we bring up topics, we have a series of potential things to segue to and then come back as hyperlinks so we can talk about the case, and then if we bring up things that we talk about, we can easily go to that and then come back to our presentation. Something different. We'll see if it works or not. So this is a 47-year-old gentleman that presented with acute onset of back pain, had left flank pain, abdominal pain, and chest pain. He had a past history of having, both he and his sister having Marfan's disease, he's FBN1, and he had this subtle ascending aortic aneurysm repaired in 2017 with a root replacement and a Bentall. He was hypertension, 200 over 120, and normal sinus rhythm. And the rest of his labs were really unremarkable. He had palpable pulses. So what would we do here? Rod, what would you do?
Well, he's got Marfan's, so he needs fixed like the rest of his family. You've got a lot of links on there. I think you've been doing too much computer work on the side.
It's a long flight.
You're too much of an expert. You were showing us last night.
So anyway, so this is a CT, and you can see that he's really dissected. Now, his CT from 2017 showed no real abnormality in the arch or the descending thoracic aorta. But here you see he has a dissection going all the way down. Yeah. So he truly has the acute aortic syndrome, and we could go to that. But I think the real question is, so now you have an acute dissection with pain. Well, the first thing we did, we said, let's decrease DPDT, got him the unit, got him his pressure under better control, and his pain went away. Here's his 3D reconstruction, just to, again, play with it, give you another idea of kind of the extent of the dissection. And got him on, good rate control and everything else, and his pain went completely away. So my thought was, I told this 47-year-old with Marfan's, you need to have an open repair. And so he said, I don't want to have an open repair. And I said, well, regardless, you're now under good, let's go with your medications, keep it there, go home, talk about it, we'll come back and talk, he's part of the Marfan Society and everything else, and say, let's see what we can do. Does that seem reasonable? Dr. Caselli, would you do that? Or?
Yeah, that's right.
Yeah, I think I would.
Beg your pardon?
I would agree with this so far.
Okay, so he said, great, I want to get out of here. So our options as we go through this really are, say, medical management, and just for fun and giggles, this needs to be up here, but you can say medical management, basically keeping the blood pressure under good control, heart rate under good control, looking at decreasing the ejection fraction, DBT, and then kind of follow up. And we really want him to mature his aneurysm. So my thought on that, was looking at the natural history of the dissection. And basically what you can see is that if unrepaired, they're going to have a high need for intervention over time or rupture. And so then we came back in and basically said, we're going to do the medical management. The other options we had, no, this is not working well. So, okay. Why is it not advancing? I'm hitting the left of the mouse.
So he's using two computers. You'll have to explain what you're doing here, man.
Yeah.
So here we go. We click on links.
Okay, but I'm trying to get, okay, that's that's acute aortic syndrome.
Okay.
But if I want to go back to advance this slide, that's not advancing.
Too many links.
Anyway, so if you could go ahead and get me. So medical management, we could go ahead and do a repair. And that's certainly going to be something where you could come in and it could be just a TVAR. You could come in and do a frozen elephant trunk, an arch replacement. And in this case, we said we wanted to wait and let it become more of a chronic aortic dissection. Let's just go ahead and go. There.
Are you going to wait till it enlarges or he gets more pain
Yeah,
or
I mean,
something? I mean,
well,
it's
that took a month.
symptomatic, yeah.
Yeah.
So basically, these are frozen elephant trunk we talked about, thoracoabdominal repair. We can do a thoracic branch graft, which we'll discuss later, carotid subclavian and TVAR, petticoat for the viscerals because the dissection went all the way down. And here's the intravascular ultrasound. And what you can see as you come through with the IVUS, there's reasonable flap movement here as you come through. And again, this is when he represented a month later. And there you can see the flap moving. And I tend to use IVUS a lot to help me to judge how chronic the dissection is and how mobile the dissection flap is. Rod, how do you use your IVUS here?
Yeah, I think we do the same. You're looking for mobility. Obviously, you saw a tear up top, and then you want to be in the true lumen like this, and you're going to come down near the viscerals and at least get a gauge of, you know, what's off the true and what's off the false, although depending on how you treat this guy, I don't worry about that anymore because we try to get the whole thing open. So.
Right. Raina, what would you do now? So he's
Yeah.
a month and a half out from his dissection, back with pain. His blood pressure's been fairly well controlled.
Is aorta bigger?
I think
No.
a few points here. It's on the acute setting, and especially for the connective tissue disorder patients, this is still relatively acute. I think we have shown that endo treatment is actually preferable and is more like a bridge to something more permanent down the line. And I'm saying this because open repair in the acute setting has significant morbidity and mortality that is actually quite different than if it is on the chronic stage. According to the definition for the timing, its chronic stage is like after like the 3 months, like the 90 days or so. So on the acute stage, if there is malperfusion, when I saw on the IVUS there that you show is like the true lumen was really like tiny. It was almost like non-existent. And that will be maybe, it's almost like a radiographic malperfusion. Depends how the patient was clinical, but definitely there is some radiographic malperfusion that could be, to place a stent in the indication here.
So you're recommending an endovascular repair in this 47-year-old Marfan's patient?
And that will be just, again, this is like radiographic malperfusion there with non-existing true lumen. I have to see how the patient is clinical. But again, the stent is just as a bridge to something more permanent down the line.
And so it appears that the dissection really goes up to the left subclavian. So how would you recommend doing it?
Subclavian, especially subclavian carotid bypass and cover the subclavian and go down to the cilia, above the celiac.
Okay. So this patient underwent a carotid subclavian bypass, and then they came in and they put a petticoat, they put a TVAR in, then a petticoat in to cover the perivisceral segment. And so now his pain's resolved, he's got a carotid subclavian, and he's got, try and get this to move forward, there we go, a TVAR in coming down, going up to a bovine arch and then the innominate. And then you can see down through the viscerals, they put a petticoat in there. Here you can see the proximal graft now sealing up the proximal aspect. Obviously, the innominate is still being perfused. And there's the petticoat coming down, but you still see a significant false lumen coming down. The intravascular ultrasound.
Well, he's still in Marfan's, though, so at
Right.
some point, Joe or Rihanna,
Yeah.
somebody's going to see this guy back.
So, I mean, maybe down the line, and Dr. Coselli can comment on this, most likely this patient is going to come up because his false lumen is going to be still there, depends how he controls the blood pressure, the false lumen is going to enlarge, so he's going to have like a chronic, aneurysm, and maybe he's going to need a further equity repair with maybe removing part of the stent or the entire stent, depends how.
Okay.
How he
So,
presents.
so he had that, and this is the completion scan now. And basically what you see is that the ascending is intact, the arch is okay. You still have perfusion of the false lumen coming all the way down, and there's no real contact. And I'm not going to go into knickerbockers and candy wrapper plugs, which would be one of the options endovascularly, but you can see there really wasn't good expansion. So I think this is a case that we're still going to need to have further discussion. And I think, Dr. Caselli, how would you manage this when he comes back with enlargement?
Well, a couple of things. First of all, if I would have treated him endovascularly, and I probably wouldn't have, I would have done a Gore branch graft into the left subclavian and probably put a Cook graft distally, but I would have felt like Arnold Schwarzenegger in The Terminator, knowing I'll be back. So, and also worry about that treatment as to, you know, we're never absolutely certain. The pain may go away, but I'm never absolutely certain about the pressure in the false channel and the descending, which is really his most significant life-threatening issue. So I disagree somewhat. I think, as I showed in my last slide, as a group, in the chronic phase, these connective tissue disorders do the best when we do thoracoabdominal repairs on them. And in the subacute phase, they still do pretty well. And I think a definitive treatment would have been an open repair down at least through his visceral vessels. And I think I would have, at the end of that procedure, I'd have had no worries about his back pain being and false lumen in the descending being a source of life-threatening issue to him. And, you know, I know it's kind of tough surgery, but I think it's a definitive repair.